Welcome to another episode from the Veterinary Research Channel. Today, we are diving deep into the world of equine health, specifically focusing on a fascinating and insightful study about Anaplasma phagocytophilum infection in horses, donkeys, and mules. This research, recently published in the Journal of Veterinary Internal Medicine, sheds light on both the common and the less typical ways this infection can manifest in our equine friends. The study, a retrospective analysis conducted at the University of California, Davis, examined the medical records of 39 equids diagnosed with Equine Granulocytic Anaplasmosis, also known as EGA, over a 22-year period. The goal was to provide a comprehensive overview of the clinical signs, laboratory findings, treatment approaches, and overall outcomes, with a particular emphasis on cases involving neurologic or muscle-related issues. Let's start with the basics. What exactly is Anaplasma phagocytophilum? Well, it's a tricky little bacterium, classified as an obligate intracellular gram-negative rickettsial organism. This means it can only survive and replicate inside the cells of its host, specifically targeting leukocytes, or white blood cells. Think of it as a tiny invader that hijacks the immune system from within. The first documented case of EGA appeared in Northern California in 1969. Initially, the organism was known as Ehrlichia equi, hence the earlier name for the disease, Equine Granulocytic Ehrlichiosis. However, advancements in genetic analysis led to its reclassification. Now, how does this infection spread? The primary culprits are ixodid ticks, those pesky bloodsuckers we all love to hate. In North America, Ixodes scapularis and Ixodes pacificus are the main carriers, while in Europe, it's Ixodes ricinus. These ticks transmit the bacteria when they bite and feed on horses, donkeys, and mules. Interestingly, Anaplasma phagocytophilum isn't just a threat to equids. It can also infect humans and other animal species worldwide. In humans, it causes human granulocytic anaplasmosis, or HGA. Once a horse is bitten by an infected tick, the incubation period lasts only a few days. After that, the clinical signs start to emerge, triggered by vasculitis or inflammation of the blood vessels. The severity of these signs can vary widely depending on which organs and tissues are affected. Some of the more common signs include a high fever, often ranging from 102 to 107 degrees Fahrenheit, lethargy, loss of appetite, icterus, which is yellowing of the mucous membranes, mild petechiation, or small spots on the skin, limb edema or swelling, stiffness, and in some instances, ataxia, which is a lack of coordination. During this febrile phase, horses may also exhibit tachycardia, or rapid heart rate, and tachypnea, or rapid breathing. It's worth noting that younger animals, those under 3 years of age, tend to show milder signs, with minimal limb edema. Typical laboratory findings often reveal anemia, leukopenia, which is a decrease in white blood cells caused by neutropenia and lymphopenia, thrombocytopenia, a drop in platelet count, and hyperbilirubinemia, or elevated bilirubin levels in the blood. One telltale sign is the presence of inclusion bodies, known as morulae, within neutrophils or eosinophils, which can be observed in stained blood smears. For diagnosis, veterinarians often turn to polymerase chain reaction, or PCR, which detects the organism's DNA in buffy coat samples. This method is highly sensitive and specific. PCR can detect Anaplasma phagocytophilum 2 to 3 days before clinical signs even appear, while morulae and neutrophils typically become visible a couple of days after the onset of fever. Now, let's get into the specifics of the UC Davis study. From January 2000 to December 2022, the researchers meticulously combed through electronic medical records, using keywords like anaplasma, ehrlichiosis, granulocytic, and rickettsia to identify relevant cases. They gathered data on each animal's signalment, medical history, presenting complaint, and current clinical signs. To analyze the data, the researchers divided the equids into two main groups, those with no neurologic or muscle disease, and those with neurologic or muscle disease. They also looked into the presence of specific genetic variants known to cause muscle diseases, such as hyperkalemic periodic paralysis, malignant hyperthermia, polysaccharide storage myopathy type 1, glycogen branching enzyme deficiency, myosin heavy chain myopathy, and myotonia congenita. Of the 39 equids included in the study, 30 were males and 9 were females. The breeds represented a diverse mix, including quarter horses, warmbloods, Arabians, Frisians, and several others. Most of these animals were brought to the hospital within a few hours to 5 days after the onset of fever. While there wasn't a clear overrepresentation of any particular breed, no horses younger than 4 years old were diagnosed with EGA during the study period. Ages ranged from 4 to 30 years, with a median of 14. Interestingly, males were significantly overrepresented compared to females. The majority of cases occurred during the spring and winter months. Among the 39 equids, 23, or 59%, presented with at least one of the following: neurologic or muscle disease, cardiomyopathy, cavitary effusion, or disseminated intravascular coagulation. The remaining 16 equids, 41%, were classified as having other presentations. 19 equids were placed in the known neurologic or muscle disease group, while 20 were placed in the neurologic or muscle disease group. The 19 equids in the known neurologic or muscle disease group showed typical signs like fever, lethargy, anorexia, icterus, and limb edema, without any apparent neurologic or muscle involvement. The 20 equids in the neurologic or muscle disease group displayed similar signs, but also exhibited neurologic, muscle, or a combination of both. Delving deeper into the neurologic disease group, 16 horses, 13 males, and 3 females presented with central nervous system issues affecting the forebrain and brainstem, the spinal cord, or a combination of both. Horses with brain involvement showed signs like obtundation, altered behavior, dysphagia, tongue paresis, multiple cranial nerve abnormalities, and absent menace response. Spinal cord disease mainly manifested as diffuse general proprioceptive ataxia, with varying degrees of severity. In the muscle disease group, 7 geldings had clinical signs of muscle involvement. 6 of them were quarter horses, and all 6 were found to carry a variant known to cause myosin heavy chain myopathy. These horses exhibited firm, painful, and swollen muscles upon palpation, reluctance to walk, and a stiff gait. Besides neurologic and muscle diseases, the researchers also noted other atypical presentations. For horses were suspected of having cardiomyopathy based on the presence of ventricular tachycardia. 4 others had moderate to marked peritoneal effusion, while 3 were suspected of having disseminated intravascular coagulation based on the severity of their condition, marked limb, edema, and petechiation. To confirm the diagnosis of Anaplasma phagocytophilum, the veterinarians used PCR, cytological analysis, or both. Clinical laboratory testing included complete blood counts and serum biochemistry panels. 13 horses showed degenerative left shifts with bands, indicating an active inflammatory response, and 7 horses had toxic changes in their neutrophils. Horses in the muscle disease group showed elevated creatine kinase and aspartate aminotransferase activity. The quarter horses with the myallele had particularly high creatine kinase and aspartate aminotransferase levels. Statistical analysis confirmed that creatine kinase and aspartate aminotransferase activity were significantly higher in the muscle group compared to the neurologic and known neurologic or muscle disease groups. Interestingly, other laboratory variables like packed cell volume, white blood cell counts, neutrophil count, and platelet count did not differ significantly among the groups. Azotemia, or elevated levels of nitrogen compounds in the blood, was observed in 6 horses. In horses with suspected cardiomyopathy, serum troponin I concentration was measured and found to be elevated. A clotting panel performed on horses with suspected disseminated intravascular coagulation revealed abnormalities such as increased fibrinogen concentration, elevated fibrinogen degradation products, and decreased antithrombin 3. When peritoneal effusion was present, abdominocentesis revealed a modified transudate. In 1 horse, morulae were observed within neutrophils in the peritoneal fluid. Cerebrospinal fluid analysis in horses with neurologic disease showed xanthochromia, but otherwise unremarkable cytology. Muscle biopsies performed on 6 horses with muscle disease revealed myofiber size variation, myonecrosis, and histiocytic infiltration. In 2 horses, lymphocytic cellular infiltration was observed, supporting a diagnosis of immune-mediated myositis, and Anaplasma phagocytophilum was detected by PCR in skeletal muscle. All horses in the study were treated with Tetracyclines, initially with intravenous oxytetracycline, followed by oral doxycycline or minocycline. Additional treatments included non-steroidal anti-inflammatory medications, intravenous fluids, anti-ulcer medication, and vitamin E. Marked clinical improvement, including resolution of fever, typically occurred within 24 to 96 hours of starting treatment. Horses with immune-mediated myositis also receive corticosteroids and muscle relaxants. The quarter horses with muscle disease showed significant improvement upon treatment, although they developed rapid muscle atrophy. All 39 horses ultimately recovered and were discharged to complete their tetracycline course at home. Hospitalization duration varied, with horses in the no neurologic or muscle disease group staying for 1 to 7 days, those with neurologic disease for 1 to 8 days, and those with muscle disease for 5 to 9 days. Short-term follow-up revealed no recurrence of signs, and the quarter horses with a allele showed improvement in muscle mass within weeks to months after discharge. This study confirms that Anaplasma phagocytophilum infection in equids can manifest in a variety of ways, both common and atypical. The overrepresentation of males in this study aligns with findings in human cases of granulocytic anaplasmosis. The seasonality of cases, with most occurring in spring and winter, is consistent with tick activity patterns. Neurologic disease was a frequent finding, often presenting as symmetrical diffuse proprioceptive ataxia. Muscle disease, though less common, can be severe, particularly in quarter horses with the allele. Other presentations, such as peritoneal effusion, cardiomyopathy, and disseminated intravascular coagulation, highlight the systemic nature of this infection. While this study provides valuable insights, it's important to acknowledge its limitations. As a retrospective study, it relied on existing medical records, which may have contained missing or incomplete data. Additionally, horses were admitted at various stages of disease, potentially influencing clinicopathologic data and morulae detection. The tetracycline protocols also varied, although all equids experienced favorable outcomes. Despite these limitations, this research offers a comprehensive overview of Anaplasma phagocytophilum infection in equids, emphasizing the importance of recognizing both common and atypical presentations. The study underscores the need for clinicians to consider equine granulocytic anaplasmosis in horses presenting with fever, lethargy, and neurologic or muscle-related signs, particularly during peak seasons. Early diagnosis and prompt treatment with tetracyclines can lead to favorable outcomes and prevent long-term sequelae. This study also highlights areas for future research. Further investigation into the potential role of the allele in quarter horses and their susceptibility to severe muscle disease following Anaplasma phagocytophilum infection could provide valuable insights. Additional studies exploring the pathogenesis of atypical presentations, such as cardiomyopathy and disseminated intravascular coagulation, would also be beneficial. Ultimately, this research enriches our understanding of equine granulocytic anaplasmosis and equips veterinarians with the knowledge to better diagnose, treat, and manage this complex and multifaceted disease. By staying informed and vigilant, we can work together to ensure the health and well-being of our equine companions. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.